We have just a little bit left of mood disorders as I finish up with bipolar disorder. And so I'm going to go ahead and start with schizophrenia in this slideshow. And this is, so I had just started bipolar disorder and did this bit of background, actually this putting us back where I had talked about the differences between bipolar 1 and bipolar 2. I'm pretty sure at the beginning, I think I restated those on Monday. One thing I like to show, I don't think this is from your book, but I like this figure a lot, as a picture is worth 1,000 words, as the brain's use of glucose increases during periods of mania and decreases during periods of depression. So normally what we see, if you remember what we've seen so far in our brains, when we've looked at brain activity, there's been a lot of green and yellow, and when something's really happening somewhere, we might see some yellow and red, and when we see something really not happening somewhere, we see blue. And this is a these are PET scans of a person with bipolar disorder. May 17th, 83, they have depression. May 27th, 83, they have depression. May 18th of 1983, they have the mania part of that. And you can see a lot of blue in the states of depression, that there's just there's less brain activity overall in comparison to the quote normal brain. But when we look at what's happening with people who are in their manic stage, I sometimes refer to this as brain on fire. There are areas that are red. There are areas that are yellow and red, showing a lot of activity. And that frontal area, I'm assuming, is at least including the anterior cingulate cortex. To just roll through some of the genetics, the genetic predisposition is supported by twin studies and by adoption studies. For identical twins, we see concordance rates as high as 40 to 70%, depending on the study, those estimates. There is a significant overlap in the susceptibility for bipolar disorder as for schizophrenia. And no one gene has a strong relationship, or we can't point to a gene and say this is going to be predictive of having bipolar disorder. I'm going to go through the treatments for bipolar disorder. I'm going to start with lithium, which I think if you've been introduced to bipolar disorder and have heard much about it, you've probably heard about lithium. It is the most common medical treatment for bipolar disorder. And I'm going to go through the story of how it was discovered, because I find it fascinating that anybody would discover anything in this manner, and I find it kind of impressive as well. So back in, I think it was 1949, John Cade, he was a chemist who was doing animal studies, and so he was working with guinea pigs, and he gave the guinea pigs urine from people who had bipolar disorder. And the urine had a toxic effect on the guinea pigs. The guinea pigs died. So it appeared to be the uric acid that was in the urine. And so he took uric acid and he was putting that into a solution to check that. And it wasn't dissolving well, so he added lithium to help the uric acid to dissolve. He gave that to the guinea pigs, and the guinea pigs were fine. And so then he gave the urine again, urine from people who had bipolar disorder, to the guinea pigs, and the guinea pigs were fine. It appeared that the lithium urate had a protective effect for the guinea pigs. And so now normally we would, if we were at animal trials, and especially these days, you'd have to go through a lot of various studies, getting permissions, defending the idea that this might be safe actually for humans as well. But what John Cade did back in the day was he just tried the lithium urate himself, and he was fine. And so then he tried it on, he had 14 patients who had bipolar disorder, and all 14 of those patients calmed down. They weren't going through those manic phases. And so that is how we discovered that lithium really calms down the manic depression, that those severe mood swings. So, lost my train of thought there for a second, and I don't want to start this again because I've already started it a couple times. That whole story of lithium is a bit much. So if you go back to the day when I had the line across, that was kind of like a line across time, and I kind of put the line across as being kind of meh. I think I got quoted on that. But we can think of that as also, maybe a little bit more positively, as I said in an earlier slide, maybe something more like equanimity. We don't really have the highs and lows. Normally, we have normal highs and lows, right? We have times when we're having more fun and life is more enjoyable, and we have times when we're in a bad mood and things aren't perfect, and we're like, that's okay, because I'm gonna have another decent time soon. Well, for people on lithium, they're really at that line. And it's not so much a sense of equanimity, it is more a sense of meh. Like they're just not having the kind of emotion, they're not having those emotions that I think to some extent are really enjoyable, and especially because there are these pleasant emotions. And so keeping them on their medication is difficult. So I'm going to skip down there to the cognitive behavioral therapy, or other kinds of psychotherapy are often added to just taking a medication. Just taking a medication does not have the same kind of outcome as also getting some kind of therapy. And often that therapy is to convince them to stay on their medication, to remind them about the bad times and the trouble they've gotten themselves into, or what that is doing to their interpersonal relationships, that they have people who love them and care about them, and that they need to really stay on that medication. If lithium doesn't work, or if they won't stay on the lithium because it is just not fun, another thing that they use sometimes is anticonvulsants. Okay, so valproate, Depakote, and Depakine are the ones I guess I have heard more about. They are usually used for people with epilepsy, and if I remember correctly, all of those are working on the GABA system. I'm going to say this wrong. Carbamazepine, that's it, carbamazepine, I know less about, and I think that it's working on both GABA and glutamate. We do see sometimes that they put them on antidepressants. Again, this, and I think I said before about these two, this can be risky, as we can bring them out of that depression, but they can get into more of a manic state, and so that can be problematic. If they're in more of a manic state, and especially if they go to a state hospital or something in that state, they're pretty likely to be put on antipsychotics, or people try them on antipsychotics. And here, they're having the same kind of side effects that we see antipsychotics have with people who have schizophrenia, but now in this case, they also aren't, they're not dealing with really the mood swings. I'm going to finish up with these treatments. I first want to just come back to that. I clicked off of there before coming back to that having cognitive behavioral therapy or some kind of therapy in conjunction with the medication is really helpful. More so, I think, for bipolar disorder than maybe almost any other disorder. I don't know that that's true, but I'm gonna. But as I'm here, it just seems so important. If we look at the drugs, at the medications, and the mechanisms by which they are working, for lithium and for some of the anticonvulsants, we see that they are decreasing glutamate activity by decreasing the number of AMPA receptors in the hippocampus. Lithium blocks the synthesis of the brain chemical arachidonic acid, so this is a chemical that is produced during brain inflammation. We also see arachidonic acid being blocked or counteracted by omega-3 fatty acids, and especially in our kind of American diet, where we tend to get a lot more omega-6s and omega-9s, and some of this is really about the ratio, but it looks like, and I'm going to show on the next slide, the kind of environmental factor, that those omega-3s that we can get from those small fish, from fish oil, from avocados, there are many different ways to get omega-3 fatty acids into just your diet, that is also helpful for people with bipolar disorder. Another thing that is extremely helpful is a consistent sleep schedule. And sometimes they also are, like people with major depressive disorder, they do have just problems sleeping. So this isn't as easy as it sounds, but being consistent with the sleep schedule can help a lot, and it helps to reduce the intensity of those mood swings. My final piece of talking about bipolar disorder is to talk about the possible effect of diet, and to come to this figure that really shows a relationship between the amount of seafood consumption in a country or culture, that's what's on the x-axis, and its relationship with the lifetime prevalence of bipolar disorder in that country or culture. And these comparisons across countries, of course, there are lots of confounds, there are lots of differences, and we're not figuring all of those differences out necessarily. In this nice regression equation, we're just looking at the relationship between two variables. But what you can see is these countries where they're eating lots of seafood, so getting lots of omega-3s in their diet naturally, like Iceland and Korea, they have much lower prevalence of bipolar disorder than those countries where they're eating very little seafood. So places like Germany, Hungary, and Switzerland. Again, lots of confounds, but so to some extent, a lot of, if you remember from, I think very early on, I was talking about good brain health is really important, and those myelin sheaths, all that, we have a lot of fats in our brain, and these omega-3 fatty acids are very important for us to get in our diet. It's also really important to think about, I think another piece of the diet is this, just how many sugars that we get into our diet, and how many things quickly become glucose and aren't giving us the kind of vitamins and minerals and other things that we need. And so I think diet is very important to consider for a lot of these psychological disorders, to at least be helpful in having good brain health. Just to break this up, I'm going to now start talking about schizophrenia. So I'm going to start by talking about the different kinds of symptoms of schizophrenia, both the positive symptoms and the negative symptoms. We have these two overarching categories, the positive symptoms being things that are present in people who have schizophrenia that are absent in quote normal people, versus the negative symptoms are things that are absent in people who are schizophrenic versus the people who are quote normal. The positive symptoms include delusions, so these false beliefs that are sometimes pretty fantastical. The hallucinations, where they mostly see or hear things that are not out in the environment, or things that are not based in reality, but sometimes they do have smell or touch hallucinations as well, or taste. Disorganized speech. Your author actually starts out with a conversation between two schizophrenics, and if you read it, you can tell that they're not talking to each other, they're not talking about the same thing, and sometimes one of the people will just go from one topic to another, and that can be kind of typical in this sort of loose associations that they make in their heads, and then they make these kind of logical leaps that make sense to them. And so to those of us who aren't in their heads, it is disorganized, as well as disorganized behavior. So those are the positive symptoms, things that we see in people who have schizophrenia that we do not see in quote normal people. He does discuss here how difficult it can be to diagnose schizophrenia. Some of these things we see in other people, and I'm going to talk about the disorganized speech at least in one of the next few slides. But things like delusions and hallucinations, we see these as they can come from other etiologies where the person is not schizophrenic. So some certain substances, cocaine, methamphetamine, people who've taken those long enough, we can see some delusions and hallucinations in those people. We see delusions and hallucinations in people with Huntington's disease. He gives us a few additional examples where we can see some of these symptoms, and we need to know that one of those conditions does not exist before we diagnose somebody as schizophrenic. They also do have negative symptoms, these weak or absent signs of emotion. Schizophrenia actually means a split in the, I don't want to say in personality, but and it's really sometimes confused by people with dissociative identity disorder, or what we used to call multiple personality disorder. But that split that schizophrenia was named after was really the kind of split between the intellect, the kind of cognition of what's going on, and the emotional reaction. And a lot of that comes from this kind of really blunted affect, or a lack of signs of emotion. They sometimes have a weak or absent speech, depending on the type of schizophrenia. And I'm also going to talk at some point, I'm pretty sure, about how there are really different kinds of schizophrenia, and they have collapsed them all into one in the DSM-5, whereas they used to be split out into paranoid, catatonic, and different kinds of schizophrenia. But they're really, the people who have schizophrenia, it really has a uniqueness to it. And similarly, I think to autism, you can say when you've met one schizophrenic, you've met one schizophrenic, which is what we say about children with autism, as it's so unique and individualistic that it's difficult to collapse them into some category. But anyway, so sometimes we see absent or a lot less speech, and then oftentimes they have worse socialization. One of the things that we're going to see can help people with schizophrenia is just social skills training. And part of this is a lack of self-care. So they have a lack of really understanding of other people and how to socialize well, but they also have a lack of self-care, which can already have people just in society have a lot of stigma against them just because they might not look clean, well-shaven, and like they're taking care of themselves very well. Usually the negative symptoms are very stable over time, and the negative symptoms are difficult to treat. So we'll talk about treatments, but most of the treatments are really for the positive symptoms. They also have cognitive symptoms, which we can think of as negative symptoms, as they have limitations of thought and reasoning that are not central to the diagnosis, but are part of their not understanding a lot of what's going on. On average, they have slightly lower IQ, but again, this is on average, and you might remember the movie Beautiful Mind with Jonathan, about John Nash, who was brilliant, right? A brilliant mathematician. And so on average, they have a slightly lower IQ. We're going to see some brain abnormalities that are going to show why they have some difficulty with inhibiting the wrong response. We've talked about the dorsolateral prefrontal cortex a couple of times, why they have some difficulty understanding social cues, and then they also have difficulty in understanding and using abstract concepts. One idea of part of what's causing some of the disorganized speech and behavior is that a lot of this has to do with their working memory. We're going to see some in their lack of ability to really focus and maintain focused attention on something. We're going to see, as we move on, a lot of different just brain abnormalities, areas that are underactive, overactive, reduced connectivity, or abnormal connectivity. One is the reduced connectivity between the sensory areas of the cortex and the hippocampus. So one study by John Kearns in 2007, he made healthy people talk and behave in incoherent ways by overtaxing their working memory. Okay, and this sounds like one of those nightmare studies that I would not want to do because I don't like multitasking as it is. But you can see how you feel you might do in this. People are given a series of pictures, and you have to tell a story about each of the pictures. If a picture comes up a second time, you cannot tell the same story. So remember, you've already told a story, and you have to inhibit that in order to come up with a new story about the picture. At the same time, they are doing a task where they have to pay attention to every second letter. And if it's the same as the last letter that you attended to, then you're supposed to press a button. So we're going to go through an example here of DL. L is the second letter. KF, F, RF. That just repeated from the last one I paid attention to. So yes, I pressed the button. BL, MT, JT. I press the button. KXH, HQ. I've already messed up. And that's actually what I thought I would not be able to not press the button for the BRB. You can see where I've already messed up, and I would press the button there, but you have to, so you're supposed to be paying attention to the second letter, and so you would not be paying attention to that first B. I was trying to give the accent on the one that I want to pay attention to. You're not supposed to pay attention to that first B, and so even though the next B is repeated, you don't press the button because those weren't the ones you were supposed to be paying attention to. Okay, so that's a hard enough task, but that's really not what they're paying. That's not what the researchers were interested in, was how well you do at that task. You're also, remember, as you're doing that task, which again already sounds hard just on its own, you're telling stories about a series of pictures. And if people are telling a story about a new picture, it's okay. They're not doing a great job. But if a picture comes up a second time, so that they have to inhibit that first story, they can't tell the same story, that's when they start to sound a lot like a schizophrenic person in having very disorganized speech, and they're not telling coherent stories. And so now we're making healthy people behave like schizophrenics in with this really cognitively overloading task. I'm going to run through some basic demographics that mostly come from your book, but maybe a couple of things from other textbooks. Worldwide, it appears to be about 1% of the people are schizophrenic. I think your author actually says it's half of 1%, but so we're going to say somewhere between 0.5% and 1% of the people have schizophrenia. It does seem to be declining and seems to be less severe than historically. However, I think a lot of that is it's difficult to tell with changes in diagnosis, and especially as we have learned more about other possible diagnoses that can be confused with schizophrenia. So I honestly think the drug-induced schizophrenia used to be assumed that was schizophrenia, but now they realize that these people who have substance abuse disorders might be using drugs that are causing those delusions and hallucinations, and so all things like that are going to change diagnoses. It occurs in all ethnic groups and all parts of the world. There doesn't appear to be any particular ethnicity or race where we see more schizophrenia. It is more common in cities than in rural areas. Your author says this is most likely due to environmental pollutions and toxins and so forth, as we're going to see that those are potentially parts of the problem, although a lot of those problems are very much whether they are intermediate or low in correlation with schizophrenia. We don't see anything that's really highly correlated with schizophrenia, and we do see more environmental pollutions and toxins in cities than in rural areas, but we also might see more social stress in some ways. So it's again, it's hard to tell what's going on exactly there, but it's definitely more common in cities than rural areas. It is 10 to 100 times more common in the United States and Europe than in developing nations. Again, why this is and whether this is partly diagnosis and partly potentially stigma in a lot of those developing nations, or just that there is nowhere to really get good medical care, those are certainly questions. And I have underneath that social support as being really important. The social support in those developing nations, because they are more interconnected and collectivistic, is different than in the United States and in Europe. And this is not including those other developed nations. So that's sort of a question too, where all of that lands. but the developing nations don't really have as many doctors. So there might not just be as many people going to get help. And then another thing I have mentioned here again is the omega-3s and BDNF and how important both of those things are. So those omega-3 fatty acids appear to at least help and mitigate schizophrenia. And then also we see some problems with the hippocampus. So we also see if we can help raise brain-derived neurotrophic factor, this can help. But neither of these things is going to cure someone with schizophrenia. It's just going to mitigate some of the symptoms. Schizophrenia is more common in men than in women by a ratio of 7 to 5, and men usually have an earlier onset. So this is usually something that we see that comes along during adolescence, and especially for men, for boys, they're having this earlier in their adolescence and maybe in their early 20s. For women, it's more likely to occur in their late 20s. So whatever's happening that men are having this earlier onset, we also see people who have an earlier onset have more severe schizophrenia. So if we look at people, there are people who have another time when you might start to show schizophrenic symptoms is in your mid to late 40s. And those people, while they have schizophrenia and they have the symptoms, they don't appear to be as severe. And particularly for the boys, the men who then had this onset quite early, the earlier in the adolescence, the worse.